Hello, everyone. My name is Liz Barlow. I'm Vice President of Marketing with Synchrony Health Services, and I want to welcome you today to our webinar titled The Pathway to Patient Health Through Pharmacogenomics. I'm really excited about this presentation. We have a lot of really good information to share with you. So I do want to go through just a couple of housekeeping items before I introduce our speakers. You do have a PDF handout, and it's under the handout section on your screen, so you can click on that and download that. This webinar is being recorded, and we will send that back out to you all probably within a week or so if you want to listen to it again or maybe share it with others. You are in listen-only mode right now, but if we have time, we're going to take questions at the end. And again, you should see a questions box on your screen. Feel free to type something in. And again, if we have time, we'll go through those at the end. And we are offering NAB and nursing CEs. But a few things to note as a result of that: if you do want to get a CE, you must participate in the entire webinar. And you need to make sure that you have provided your professional license when you registered. An evaluation will be coming to you via email, and that needs to be completed within the next 48 hours. So again, that's going to come via email. Make sure you complete the evaluation, and then you'll receive your certificate via email within the next 30 days. So if you don't have the opportunity to do all of those items, then it will result in CE forfeiture. So I did want to go make sure. They are very strict about those guidelines, so I wanted to make sure I went over those. So I would now like to introduce our speakers. First, I want to present you with Rob Leffler. Rob is Vice President of Clinical Services here with Synchrony and is a pharmacist. He has been with Synchrony for over 9 years and has spent most of his career working as a pharmacist in long-term care. He is strongly involved in FASCP, which is the American Society of Consultant Pharmacists, and is currently on their board of directors. Also want to present Kathleen Scheffler. Kathleen is a speech-language pathologist and a clinical support specialist and been with Synchrony Rehab for 12 years, transitioning to the clinical support role in 2016. She also has a strong background in geriatric care and provides education on Medicare compliance, clinical documentation, and program development. So I'm going to go through quickly the objectives for this presentation. If you don't know much about pharmacogenomics, which is a pretty big buzzword right now, you're going to learn a lot more about it today. But the objectives are for us to review the science of pharmacogenomics, and you're going to see that abbreviated as PGX throughout the presentation. Discuss the impact of genetic variation on increased risk of side effects. Discuss the pharmacist's role in report interpretation, and then we're going to pull the rehab side of this in. How can rehab therapists assist in identifying residents who could benefit from this type of testing? So lots of great information to share. And with that, Rob, I am going to pass it on to you.
Thank you. Let's see, let's advance this slide. There we go. So we've got a lot of information for you to sort of squeeze into this hour. And so we're going to spend the first little bit just kind of talking generally about pharmacogenomics, and then I'm going to pass the baton over to Kathleen to talk about the therapy perspective, and then we'll take the last, I don't know, 20 minutes or so to kind of circle back and talk about some practical applications. So just to kind of ground us and get started, we wanted to kind of take this approach where we looked at this from a pharmacy perspective, from a rehab perspective, and how we can allow each team in the interdisciplinary team to excel in their unique area to improve patient outcomes. So there's a lot of talk and a lot of throwing around of terminology about precision medicine or personalized medicine. I thought that would be a good place to start. Back in 2015, in the State of the Union address, they announced the launch of the Precision Medicine Initiative. And, you know, there's a lot of talk about, well, aren't we already personalizing medications or medicine? We're giving certain doses and certain drugs to patients based on other diagnoses, on their kidney function and things like that. But that then begs the question, why do we not always get therapeutic responses that are predictable? A lot of times with these drugs that we use a lot, some people have certain side effects and other people's don't. So when we put kind of our genes, our DNA into that bucket with all of that information, our genes can correlate to how well and sometimes how even whether a drug will work. Because it's not a one size fits all scenario. A great example of that is antidepressants. The SSRIs is a class of antidepressants, and you can see here that not everybody is going to respond to an SSRI or a certain SSRI, or they may respond to one and not another. Same way with asthma drugs, diabetes drugs, arthritis drugs. Every time we give somebody medication, there's not always a predictable response. So with personalized medicine, we're trying to provide the right patient with the right drug at the right dose, and of course at the right time. Our genes, our protein biomarkers help predict how we are going to respond to medications and adverse effects. And that's really the study of pharmacogenomics. It's a subset of personalized medicine that we can implement in certain practice settings and with certain medications. And so on the right hand there, you see if we do a DNA profiling test and you look at everybody up there in the left-hand side, everybody in that group has the same conditions, but some of those people are turquoise and some of those people are orange. And what that is representing is those purple people have a good response. They respond well to that drug. The green or turquoise people don't respond or don't respond adequately. And the people that are orange there are representing the people that might have unexpected or bad side effects from those drugs that the people that are getting an overall good response are not experiencing. So when drugs are designed, they're really designed and tested and developed for the average, quote unquote, patient. They help some people, but not others. And so we're customizing drug or trying to customize drug selection based on personalized factors like their genes, the environment that they live in can affect that, their lifestyle. What we're not doing here is creating custom medications for individual patients. And this initiative is constantly expanding to a variety of other medications. So just a few definitions to get us started. When we're talking about genomics, the genome is the study of the entire DNA sequence. That's what they're referring to when we say genomics. Pharmacogenomics is a study of how a person's genes affect a person's response to certain drugs, and more general term for the interface of genomics and therapeutics. When we hear the term pharmacogenetics, that's the study of how one gene affects a person's response to a particular drug. So pharmacogenomics is a little more general term, and pharmacogenetics tends to be a more specific term talking about one gene and one drug. But we do see those terms used quite interchangeably. And you'll see a variety of capitalization and not capitalization in PGX if you do some research. So when we talk about pharmacogenomics or pharmacogenetics, we're talking about how people respond to certain drugs based on their genes. As we hone in on geriatrics, which is our area of expertise and specialty, treating patients can be difficult because of all the drugs they receive. About 40% of geriatric patients are on 5 or more prescription medications, and we see long-term care residents often taking 8.5 prescriptions on a regular basis. Certainly there's some that take more, some that take less. About the average, according to a study in the Journal of Clinical Pharmacology, was that 8.5 was the average at that time. The prevalence and severity of the adverse drug reactions that are experienced are increased in older folks. 5 to 10% of hospitalizations are related to adverse drug reactions, And older people are 4 times more likely to be admitted to the hospital because of an adverse drug reaction, and more likely for those adverse drug reactions to be reversible. So why do we see more adverse drug reactions? Well, there's certainly more comorbidities in elderly folks. There's more polypharmacy. In the right-hand side, you see as we get older, 5 or more meds or drugs, about 40%. And they also have physiological changes. So there's changes in the way that they metabolize drugs. There's changes in the way that they absorb drugs. And so that's why we're seeing more adverse drug reactions in the geriatric population. So where does pharmacogenomics intersect with this? Well, we see a higher frequency of changes in, or not changes in DNA, differences in their DNA that reflect how they're going to respond to medications, either their response or their risk for adverse drug reactions. In this particular study, greater than 3 hospital admissions in the last 2 years and taking greater than 5 medications, they saw a significantly higher frequency of those patients having changes from the normal metabolizer when compared to those admissions. When we look at the CYP450 substrates, we saw greater readmissions and greater healthcare costs in patients that had polymorphisms. And we'll talk a little bit more about that as we get further into the presentation. Here's one example from cardiology. Plavix, prasugrel, ticagrelor are all used to prevent clots. If we get too much drug, then we run the risk of having excessive bleeding. But if we don't get enough drug that's being utilized by the body, then those patients run the risk of clotting. And so specifically with clopidogrel, there are dosing guidelines for changes in the CYP2C19 pathway. And you see the CPIC dosing guidelines there on the right. Ultra rapid metabolizers on the left, extensive metabolizers, they can use standard dosing of clopidogrel. If they're intermediate or they're poor metabolizers, then you should not be using clopidogrel. You really should be using a drug like prasugrel or ticagrelor. It's right in their FDA label. It was updated in 2016 that you should consider alternatives in poor metabolizers. So there's no age dosage adjustment on the FDA label. It's only a genetic adjustment. And so if someone's taking a drug like clopidogrel, which is available generically, it's fairly economic. It works great. But if you are a poor metabolizer, you're not getting the desired therapeutic benefit. You run the risk of developing clots, which is why those patients would be taking that drug. Similar example when we're talking about depression. There's a STAR-D study that found the percent of patients achieving remission rates decreases with added medication trials. So there's a lot of trial and error prescribing with antidepressants. And they found that if you failed drug 1 and then you had to try another drug, each time they tried another drug, the potential for them to find remission from their depression was decreased. And they also found that healthcare professionals were underestimating the patient's emotional burden from the multiple medication failures. And so down here in the bottom, we show an example with geriatrics. We always talk about using a lower dose of citalopram in geriatrics because of the risk of QTC prolongation. But it's really not dose or serum level associated. It seems to actually be associated to a change in their 2C19 pathway. That's one of the genetic pathways that are metabolism pathways that drugs are metabolized by. Citalopram is metabolized in that pathway. And so if you have a variation there, you actually would be at increased risk of a QTC prolongation because of your genes, not necessarily because of your age. So threw a lot of information at you, and we know a lot of information. There's a lot of drugs that are impacted by pharmacogenetics and inform our decisions by pharmacogenetics when we have that information. From the top 200 most frequently prescribed drugs, there are 13 medications that have relevant pharmacogenetic information in their packaging. About 25% of patients take at least one medication where pharmacogenetic information has been shown to be relevant. And more than 90% of medications commonly used are metabolized by just 6 liver enzymes, and those enzymes are assayed with PGX testing. And so I think it's a good time to point out that while there are a lot of drugs that go through those liver enzymes that we're able to get information about through PGX testing, there are also drugs where PGX testing would not apply. And so you would want to think about what medications a patient is taking or may need to be taking when you're considering doing PGX testing. There are a lot of drugs that outside of packaging also have guidelines. CPIC, I mentioned CPIC earlier, that's the Clinical Pharmacogenetics Implementation Consortium. They talk about antidepressants, anticoagulants, pain medications. They have 23 different guideline publications. There's also the Royal Dutch Association, 52 drugs mentioned in their guidelines. From the FDA, there are 130 commonly prescribed drugs that have dosing guidelines that are based on PGX. And so if we don't have those PGX results, we're probably not really dosing some of those patients appropriately. And 80% of the population carries at least one gene mutation that will affect drug metabolism. Here's an example of that from our FDA dosing guidelines with Rexulti or brexpiprazole, fairly recently in the news. But 7 to 10% of the population have decreased clearance of 2D6, which is the pathway that Rexulti is metabolized through. And we see adverse drug reactions are increased due to drug exposure at standard doses for those 7 to 10% of patients. And they do recommend dose adjustment by 50% if you're a poor metabolizer, if you're taking a 2D6 inhibitor, which would be a drug that would inhibit that pathway, or an inducer. And in fact, they even say that ultra rapid metabolizers may metabolize too quickly to have a therapeutic response. Now, with all that knowledge that we have, there's still a lot to learn. We find that 29% of patients or physicians report an education related to pharmacogenetics, almost 15% in medical school, 23% in postgraduate training. Only 10% felt adequately informed when surveyed to make decisions about pharmacogenetic testing and test result interpretation. And only about 13% have actually ordered a pharmacogenetic test in the last 6 months. And that's some older information now, and so that's probably increased a little bit, but we're still finding a lack of knowledge, but that is changing over time. And with that, I'm going to pass it over to Kathleen to talk about how rehab therapists can help identifying patients that could benefit from pharmacogenomic testing.
Thank you, Rob. We in the rehab world are really excited to be represented and invited to the presentation today. I know personally I've really enjoyed researching the role of rehab and learning more about this really fascinating topic. For this rehab section, I'm going to start with a review of who we are and what we do. So when we talk about rehab today, we are referring to our practicing clinicians in occupational therapy, physical therapy, and speech-language pathology. So our Synchrony rehab clinicians, we serve residents in a wide variety of settings, such as we see here on the slide, outpatient facilities, independent living communities, in their home through home health, assisted living, skilled nursing, and of course, long-term care and residential campuses. Next slide, please. So when we're thinking about the role of rehab and collaborating with pharmacy, traditionally, it's been a very hands-on approach for rehab, and it becomes where we incorporate our therapy goals. So when we think about medication management, if you will, we see typically that occupational therapy and speech therapy work with our patients or clients or residents on a number of different things, as this slide shows. And these are just a few examples. But with memory and cognition, we may have occupational therapy and speech therapy partnering to look at things like setting up medication reminders, so our patients are taking medication on time. There's a specific memory technique called spaced retrieval that's often used to help with this. We're helping our residents or patients set up pill boxes or pill containers to stay organized, and helping to develop tracking systems to avoid missed or double dosing. Our OTs typically focus on fine motor and vision skills. So you can see a few examples that we've listed here, such as, managing medication storage containers, or the medication bottles themselves, opening and closing caps, popping out pills, twisting caps, or even sometimes squeezing a tube of topical medication. Occupational therapy may also be involved with adaptive equipment for task modification. So maybe something like magnifying, lenses for reading labels to ensure we're taking the correct medications, being able to administer medications by using fine motor skills by taking those little tiny pills out of those containers. And whereas speech therapy, of course, would be looking more at swallowing function and safety with oral medication. So our Synchrony rehab clinicians are educated and accustomed to really communicating with our campus consultant pharmacists through Synchrony Pharmacy. And we have this ability to directly communicate and ask questions or express concerns to our consultant pharmacists within our campuses. I know when I was a staff SLP, I frequently asked our consultant pharmacists questions about appetite stimulants for some of our patients who had dysphagia, maybe with limited intake, and nursing was complaining or concerned about weight loss. I also had a lot of questions for our consultant pharmacist about medications that sometimes looked like they were making dysphagia symptoms worse. So it's really great to have that collaboration and that ability to consult and ask questions. Next slide, please. So when I was learning about pharmacogenomics, it really made me take a closer look at what we do in the rehab world that actually correlates and makes us part of the team in promoting this science. As therapists, we're trained to consider what medications a patient is, what medications a patient may be taking. And it's actually part of our evaluation process across all three therapy disciplines. When we're setting up that initial plan of care, we're looking at the patient as a whole. So we're looking at their prior level of function, their discharge environment, but medication and what they're taking is a big part of that also. As therapists, we're trained to understand and consider some of the more common side effects of medications and how they can potentially impact function, especially, of course, as it relates to rehabilitation. All three therapy disciplines pay special attention and give consideration to patient performance during our therapy treatment. And that may involve something like the timing of therapy sessions in relation to medication administration. So for example, with pain medication, our physical therapy teams and occupational therapy teams too certainly want our residents and patients to be as close to pain-free as possible during treatment in order to maximize the effectiveness of strengthening and range of motion exercises. Another responsibility that our therapists have is to advocate for our patients based on the effectiveness of medications or sometimes lack thereof. And of course, we're also helping our patients and residents to report any adverse side effects. So depending on the setting, our therapists may be spending a lot of time with our patients. Sometimes we see patients 3 to 5 times a week. So we really get to know them, we get to know their skills and their functional level. And sometimes we may be the first or one of the first to realize that there's a change in the patient's functional performance or condition that may be associated with their current medication regimen. As therapists, we use standardized assessments to develop a baseline and then to measure progress over time. So when that progress is stalled or declines or changes, medication considerations, and I think now more than ever, those medication considerations become part of the clinical problem-solving process. As I mentioned, therapists are trained to collaborate closely with the IDT, and that of course includes the consulting pharmacist. So when nursing and pharmacy and the physician and therapy all come together and express our concerns from our specific angles, and that may wind up including medication issues, I think the team as a unit can really begin collaborating and hopefully drill down into what may be going on or what changes might need to be made in the type, dose, or timing of certain medications. Next slide, please. In the settings that I mentioned before, as therapists, we see that most of the patients that we work with for rehab do fit into the parameters of potential candidates for the PGX testing. Many are over 65, they're taking multiple medications, and they're presenting with conditions associated with PGX testing as shown in the next slide. So these are medical conditions we're familiar with and we typically see in our patients, and they're also associated with medications that correspond, as Rob had mentioned, to current PGX testing benefits. Next slide, please. I think it's really important for rehab clinicians to recognize the benefits of PGX testing based on what we observe and assess during our treatment sessions. And that, of course, as I mentioned before, includes any adverse side effects that may impact the patient's functional gains and sometimes even diminish quality of life. We're also responsible for helping to report when medications don't seem to be effective for a specific patient. As Rob mentioned, different people respond differently to the same medication. So knowing this sooner rather than later is really a benefit for all our patients. And as rehab clinicians, it's really important for us to learn and recognize those medications on these PGX testing lists with known information. As clinicians, we really need to be seeking additional education and understanding of PGX testing and benefits and the relation to improved patient outcomes. I think we should be promoting this within our field of practice and also being part of the team that's educating our patients and families about the benefits. Next slide, please. So noting some of the common side effects that impact function and quality of life as a consideration for possible PGX testing is important. And of course, communicating that to nurses or physicians or our consultant pharmacist is of course the next step. As rehab professionals who are working with patients on a very regular basis, we observe and we hear about these side effects frequently during rehab treatment sessions. So, especially in skilled nursing, long-term care, and assisted living, we're seeing those falls, or we're hearing about increased muscle or joint pain. We're recognizing when there's increased confusion or swallowing issues, weight changes, and dry mouth and gastrointestinal issues are also a big complaint for a number of our patients. So when we see these side effects and we see the impact on function and progress of treatment, and we're reporting that, but something else that I was thinking recently that we should be considering is other implications, especially for our more independent patients. So those that we might be seeing through home health or who are coming to us as community outpatients. Sometimes these side effects or a specific lack of effectiveness with medications can lead to decreased compliance with taking their prescriptions, which of course then that leads to a whole host of other problems. So next slide, please. So as we kind of wrap up here the rehab section, I think on the rehab side of things, as we continue to learn more about this fascinating science, I think the role of collaboration becomes more evident in order for us to be able to promote that patient first, true quality care. And I think it's important that we're increasing awareness of PGX testing and benefits across multiple healthcare disciplines, because really overall that's going to benefit the patients the most. And some of those benefits will be adhering to more effective medication regimens and enhancing functional progress, patient outcomes, and of course, quality of life for those in our care for as long as possible. So I'd like to thank you, Liz and Rob, for allowing us on the rehab side to explore our role. I'll hand it back over to you now, Rob. Thank you.
Thank you, Kathleen. So we're going to talk about some practicality of how to apply pharmacogenomics. So, you know, there's a lot of talk about the triple aim of healthcare: improving patient care, improving patient population health, but also reducing per capita cost of healthcare. And so I think it would be a good time to talk a little bit about the cost. So we should take it in the frame of how it impacts the cost of drug therapy. When you talk about a drug like, we used this example earlier, and so I think it's good to look at it again. Plavix is available generically as clopidogrel. It can be anywhere from like $9 to $90 a month for that therapy. And this information is a little old, but the information comparatively is still valuable. Effient about $300 to $400 a month. Brilinta about $300 to $350 a month for a month's supply. And so if you can take a generic like clopidogrel, there's a potential savings for about $225 to $300 a month by using that generic. But like we talked about before, Plavix is not going to work for every patient. And so by knowing their genetic profile, we can help prevent an additional blood clot. We can prevent excessive bleeding by using appropriate therapy. And so, you know, we have to weigh that against what that blood clot costs. We see it used a lot for long-term care residents with 5 or more medications. There's a study that looked at this specifically. The patients were all over the age of 45. There were 132 patients that were analyzed looking at 17 different genes, and that information was reviewed by a pharmacist for clinical recommendations. And in this particular study, about half of those tested were found to have actionable findings. And of those actionable findings, the pharmacist's recommendation was for an adjustment from anywhere from 1 to 3 drugs. In that study, the drug cost savings alone was an average of $621 per patient saved annually. And when you think about a patient staying in a facility for 2 to 3 years, that's a big savings over that time. You know, there were some recognized limitations, some variability from pharmacist to pharmacist or interpretation of guidelines, but still a significant savings. And another example, 76-year-old male taking these medications. He was an ultra rapid metabolizer of 2C19, also GG for HTR2A. So had increased susceptibility to SSRI-induced side effects. So I look at that drug profile and I see that he's on sertraline. So the sertraline in this situation was discontinued because it probably was not contributing or having little contribution to the combination antidepressant therapy, which he was also receiving mirtazapine. You see there in the second row, that's Remeron. So 2 different antidepressants in there. When I see patients receive dual antidepressant therapy, is it because the first drug really wasn't working very well, and instead of discontinuing that first medication and putting them on something else, we discontinued that first medication, or it wasn't obviously adequate? So in this situation, discontinuing the sertraline provided an estimated savings of about $900 a year. And we'll talk about how this testing is billed in a minute. So it seems pretty simple, right? Let's just jump right in. Well, it's not that simple. There are other drugs that affect the responses to the first drug. So drugs that may induce or inhibit a genetic pathway or an enzymatic pathway, excuse me, a metabolism pathway. There are drug gene interactions. Some might affect more than one gene. So there can be more complicated interpretation. Sometimes we don't have good guidelines, but we can extrapolate some of the information that is available to apply it across to other medications, even though there's not clear guidelines for those. So it does get fairly complicated. It is not a simple science, but there certainly are benefits. We can improve the efficacy of therapy for patients. We can reduce and avoid adverse drug reactions. Selecting a good starting dose for these patients is certainly beneficial, and reducing total healthcare costs. We talked about the change with the sertraline or the testing of those nursing home patients where the average savings was significant. Some of the potential challenges, training and education, people knowing when to order a test, how to obtain the sample effectively, what to do with those results, what's the individual patient level cost, and the fact that it doesn't help with every medication. So, as far as when to order and usefulness, knowing, working with a pharmacist that is familiar with pharmacogenomics can help you determine who you might want to test, or if you have a question about testing, you could talk to a knowledgeable pharmacist about whether it might be informative for that patient. Obtaining the sample is actually fairly simple. It's a cheek swab that gets put in a vial and sent off to a lab. With what to do with the results, when we do testing through our pharmacy, it is not done at our lab. We do use an outside lab, and there are a variety of them. We like using GeneIQ. They send us the test results. We provide the test results to the prescriber and to our facilities. With pharmacist recommendations, our pharmacist reviews those test results with the patient's medication profile to provide actionable recommendations. And I think that that helps the testing be more effective and more useful. And then we also track that information in our system so that we can hopefully utilize that information for future prescribing decisions. Other potential challenges, and I won't go into a lot of detail here because I want to get to some of the other information, but things like epigenetics and phenoconversion. Epigenetics is a gene expression that's modified rather than the genetic code itself. So you may look at someone's genetic profile and say they're a poor metabolizer, but they're actually responding well to a medication, ironically, in a way that you would not expect. So that's an example of what could happen. A genotype for phenoconversion is, in one test, showed a 4% of the people were expected to be poor metabolizers of venlafaxine, but blood tests actually showed that 27% were poor metabolizers. So they were actually more people responding than you would expect purely on that genetic test. There's a lot of concerns that patients will express about discrimination based on genetics. And there was actually an interesting situation brought out by the Burlington Northern Santa Fe Railroad. They were doing secret genetic testing of their employees to determine if they had a predisposition to developing carpal tunnel syndrome. And that resulted in the development of the GINA Act, the Genetic Information Non-Discrimination Act, that prohibits discrimination by health insurers and employers from utilizing genetic testing to discriminate. And so people say, well, I don't want my genetic information out there. And that's really probably not a significant or accurate concern. Discrimination based on the genetics, these tests do not provide disease risk information. So, there's a lot of people that You know, if you do a 23andMe test, it talks about some disease risk. That's not what pharmacogenetic testing is doing. It is giving information about drug metabolism. And so we don't have the same ethical, legal, social implications with most PGX testing as when you're talking about more broad genetic testing or that whole genome sequencing that may put some liability on physicians or provider institutes. How do we succeed? So some of the things that we feel like really help pharmacogenomic testing be successful is the use of a single lab. The why I like to see a single lab used rather than a variety of labs like there are out there is you can become accustomed to the reporting from that lab, develop that relationship with those people at the lab, but the reporting is really a big piece to having that consistency, I think, is very helpful. Working with a PGX trained pharmacist, so a pharmacist that understands how to utilize that science. Back when I went to pharmacy school, they didn't talk about pharmacogenomics. We talked about rapid metabolizers or slow metabolizers, but they really didn't put this kind of information on it. And so certainly prescribers around my age or older may not have been exposed to it. And I had the good fortune of being able to go through a training and learn about this fascinating science. You also have to use it as one piece of information with other available data. We talked about if the test shows that they're not going to respond well to venlafaxine, but they are responding well, you look at their PHQ-9 scores, or a geriatric depression score, whatever test you're using to evaluate them, and they're responding well. If it's not broken, we're not going to fix it in a situation like that where it's much more an objective description. Having reasonable expectations. I once worked with a family member who had their mother tested for pharmacogenomics, specifically to look at how her pain was being treated, and she was a normal metabolizer. And her daughter was very, very happy to know that her mother was a normal metabolizer, knowing that her mother should have normal responses to our usual pain therapies without excessive side effects was good news to her. So being a normal metabolizer is not a bad thing. Certainly can be used to guide therapy selection and making sure that we're using evidence-based recommendations and guidelines for how to interpret those results. So going on to talk about some situations that you might think about who you might test. With mental health, I think about patients that are on 2 or more psychoactive medications, particularly in the same category, triggering on the MDS for symptoms of depression without treatment. There's been psychiatric hospitalizations, experiencing side effects, persistent symptoms or poor responses to current therapies. There's actually a study that showed 87% of patients on SSRI, serotonin reuptake inhibitors, have some kind of gene conflict that would help. If we knew that, we could help select a therapy. Knowing, we also talked about this earlier, but only 30 to 40% of patients achieve remission with their first drug. And if we could pick a better first drug off the bat for an antidepressant, all the better. About 50% of antidepressant responses due to genetic polymorphisms. For the longest time, we've always matched drug to symptoms. So if someone was having trouble sleeping, then we might give them an antidepressant that was sedating. But that didn't necessarily indicate that we would get a better response for the depression, which is really what we're trying to treat. So using pharmacogenomics in those situations can be helpful. It can be used for pain management. I think about new patients with a new indication for treating pain or some starting a new medication. If their symptoms, persist despite changes in therapy, that would be an opportunity. If you see patients that change drug therapies frequently, that would indicate to me that their therapy is not working. A lot of side effects or allergies. We could use that testing to look into an alternative. When you talk about side effects with pain management, about 80% of patients that have significant adverse events related to opioids have altered 2D6 metabolism. So if we knew that up front, we could pick something that may not be as causative of those adverse drug reactions. Cardiovascular disease, we talked about this, but patients that are have European or African ancestry, about 30% of the time have a change that would indicate that they should not use the generic Plavix. It's much higher in Asians. 36% of the population has a 2C19 variant causing clopidogrel to be ineffective, and 28% have a variant that increases their risk of bleeding on clopidogrel. So you know, we've talked about Plavix a lot, but it's a great example of how we can use this science and how important it is. Statins can be evaluated. There are some dosing recommendations based on phenotype with simvastatin, zevastatin. We see a lot of side effects, so that may indicate that we'd want to use a different statin. It can also be helpful for dosing warfarin. Personally, in my practice, I don't do PGX testing if we're only looking at dosing of warfarin, purely because by the time they're getting into long-term care, we've got patients that are typically on it already. We're not starting new patients. If I was running a Coumadin clinic and doing warfarin dosing and I had a little bit of lead time that I knew somebody was going to be coming out of the hospital, switching from heparin or something at the hospital to warfarin, then I might do that testing to help determine a starting dose. But typically you're going to adjust your dosing for warfarin based on PT and INR results. Some other things, if patients have a significant mental status change, that could be because of a medication, and so pharmacogenomic testing could help determine that. Unexplained falls, increased fatigue, unexplained weight loss, not responding to therapies, an increase in need for help with their ADLs, and that kind of, you know, some of those play into those areas that Kathleen brought up in her portion of this presentation today. So sometimes when we're not quite sure what's going on, it may be that a pharmacogenomic test could be beneficial. So how do you get started? It's just as simple as getting an order from a prescriber for a pharmacogenomic test. The test kit will come to the facility, fill out billing information, there's test swabs, there's a form that gets filled out. All of that goes to the lab. The lab bills Medicare B as in boy, so it's covered typically for most patients under their Medicare B provision, and so there's no cost to the facility, there's no cost to the pharmacy. We don't get any kind of reimbursement for it. It is a service that we provide as far as interpretation is concerned. And those test results follow the patient for the rest of their life, so your genes do not change over time. So once you get that first pharmacogenomic test, those test results would apply to future prescribing decisions in some situations. And again, it applies to a lot of medications, but not all medications. So how do we persuade somebody that may be hesitant to order a test? Emphasizing the benefits, like the opportunity for less trial and error prescribing, the opportunity to minimize adverse drug reactions for patients, improving their quality of life, and helping to manage their health care costs. I mentioned that it's billed under Medicare B, so they will many times have a normal Medicare B lab copay that the lab would then bill for. And the lab that we work with is great with helping determine costs based on diagnosis or reason that the test is being ordered, to help predict how much that cost is. And some people are willing to just pay out of pocket for testing as well, even if it were not to be in the rare situation to be covered. So we do get some frequent questions from prescribers, and I thought it would be good to kind of talk about those, talking about them not being trained to interpret the results, but working with a group like Synchrony Pharmacy or your pharmacy that helps interpret those results is beneficial. thinking of it as a collaborative process, setting goals for training. What's the purpose of the training? Or the testing? Why do you want to test this certain patient? We do hear sometimes a doctor will say, I don't want to have the liability of having that information available. And that, I actually turn the tables on that, because I think it's a liability to not have that information available. When the FDA puts it in a package insert, that you should adjust dosing, and let's use the Rexulti example this time, that you should adjust the dosing. You've not adjusted the dosing. You don't know what their PGX profile is, but the FDA says you should have that information. I think that's a liability. We hear all the time, there's not enough evidence to support its use. There's more and more evidence all the time. And while that may have been true at one time, we talked about the guidelines from Pharmacogenomics, from CPIC, from the FDA, and using those evidence-based recommendations. There is good evidence out there for the use of pharmacogenomics. And before we go to hopefully a few questions, if you're, I'm sure there's probably a lot of questions that have come up. You can type them in the questions, or certainly reach out to us after this. I'm happy to sit down and have a separate conversation, look at certain patients if you like. But we get questions from families and residents, or you may, how much does it cost? It can frequently be predicted, but we don't always know for sure until that claim is put through. But it can vary from nothing to an average of less than $350 for that one-time, once-in-a-lifetime test. Contact the lab provider and see if they can determine whether coverage is available. I'm thinking about it in terms of preventing a heart attack if we're talking about cardiology, or improving patients' quality of life if we're talking about something like depression or their mental health. Certainly those have value, and thinking about what the value of that is versus the cost of a test. And again, it's typically going to be the copay that they would pay for other labs. And how much is it effectively worth treating behaviors depression, as I just mentioned. Occasionally, we mentioned this, but you hear about concerns for having DNA tested, or social concerns about genetically linked diseases. The information, just like any other information in healthcare, is kept completely private. It's HIPAA protected. And these tests really are looking at drug metabolism. They're not genetic tests, they're pharmacogenetic tests. And so we're looking at drug metabolism when we're talking about those tests. So I'm going to open up my little window here and see if we've got any questions so far. Thanks for jumping back on, Liz.
Sure. I'm not seeing any yet, but you all feel free. We've got a few minutes here. I mean, Rob and Kathleen just went through some really good information. I know it's probably a lot to absorb, but I've got a question for you, Rob, and I think I know the answer, but you talked a little bit about the information going into medication prescription packaging. I mean, certainly with the rise of this, I would anticipate seeing more and more of that type of information right in the future. Are you seeing a change slowly in some of the inserts and packaging?
Yeah, the FDA is looking at that all the time and getting new information. And we see, even when it's not in package inserts specifically, there's a lot of guidelines that are available through CPIC, through Pharmacogenomics, which they rate their information. And so there's very high level, very well-researched information about this gene polymorphism will affect this drug and what that means exactly. And so we can use that information. And you know, there are situations where we know that this drug is metabolized by this enzyme, and we can see that this patient's a poor metabolizer. And so I didn't mention it earlier, but since we don't have any questions, I can go into it now. There's a lot of ways this information can be used, because some drugs have to be metabolized to be active in the body. And some drugs go into the body and they're already active, and they get metabolized to be inactive. And so if you're not metabolizing it from an active perspective, then you've got a lot of active drug building up because they're not metabolizing it as quickly as the average patient. And likewise, if it's a prodrug, if it's not getting metabolized, you get all this drug in the system, but they're not metabolizing it very quickly, and so you're not getting as much active drug. And so this science delves into that and helps kind of say, okay, well, you're not responding well to this drug, and you can say, oh, well, they're a poor metabolizer, and it's because they're not turning inactive drug into active drug, just as an example. So,
and as clinicians, we're seeing the side effects of those that Kathleen talked about, right? And we don't know what's going on.
Mm-hmm.
Yeah. Right.
You know, we talk a lot about falls as an organization. There's, you know, if you've got patients that are falling repeatedly and you really can't put your finger on it, maybe a pharmacogenomic test would show that, oh, we're probably getting a lot of side effects from this drug that we may not have realized. Okay, so we got a couple questions now. Do you see them? One person asked about the benefit for someone with Parkinson's disease who is very intolerant to medications. And so that's a great question. It's something that I actually happen to know about because we've gotten a similar question before. Most of the purely Parkinson's disease drugs are not impacted by the enzymatic pathways that metabolize those drugs. And so while have some sensitivities to some of those drugs, we don't have information from pharmacogenomics because they're not going through those pathways that's going to affect it. There are other medications we may be able to make some determinations from, but specifically Parkinson's and how well they're going to respond or not respond or side effects, those traditional Parkinson's disease drugs don't fall into that category. And so great question for Kathleen. Best practice for rehab side to introduce this to residents, family, and doctors?
Well, that's a really good question. And I think it is, as we've mentioned throughout the presentation, a collaborative effort. So we definitely want to make sure as rehab clinicians that we are learning as much as we can, but we also want to pull in our consultant pharmacist whenever possible to help have that conversation, especially with physicians and our providers, our nursing team, and even to talk with families. Because I think when the physician or the provider is on board, it's much easier to bring it up with residents and families and to help get the process going. But good question.
That's a great question. I don't see any other questions right now.
Not either. Got a couple of minutes, but I'll go ahead and just start winding things down and thank everyone for their attendance and participation. Again, a lot of great information was shared. Thank you so much, Rob and Kathleen, for your expertise in this. And we will close the session for now. Again, a reminder to please complete the survey that you will receive via email in the next couple of days. So thank you all for your time.